So now we will continue with the same line of thinking, no? The reconstruction of the thumb. And of course, it's not only in thumb hypoplasia, we have other pathologies that we need, from trauma, congenital, we need to reconstruct the thumb. And in the technique place of the PULM Talks, Dr. Shen will talk about pollicization. Thank you very much, Doctor.
Thank you. Thank you, the course professor. Hello, everyone. So, and thank you for joining me today. So it's a pleasure to share my knowledge with you. And I will be presenting my surgical technique for pollicization, getting you. Okay, thank you. So I'll also discuss the design considerations and reformation and to enhance both function and aesthetics. Yeah, I'm Dr. Xiaofang Shen. I'm from China Suzhou Children's Hospital of Suzhou University. So pollicization is a life-changing procedure for patients with congenital thumb hyperplasia or conditions like five-finger hands. Over the years, surgeons have made significant reforms to improve this technique. However, challenges remain in optimizing both function and aesthetics. Common issues include some appearance, web space contracture, and poor thumb position. And there are multiple variations in skin design, which I have found to be a key factor in determining both the aesthetic and function outcomes of the procedure. The most common pitfall is creating a thumb that appears too long, resembling a chamfergine thumb. And another common pitfall is extend the leg of the PRP joint. PRP joint is a new thumb will be MP joint, which can lead to an unsightly appearance, resembling botanial deformity. This issue can be addressed with appropriate tendon and intrinsic muscle rebalancing. And we look at the picture is the first and the second picture is, and after the pollicization, the thumb we can see the new thumb MP joint is the extend limited, and the third thumb is my hand. We can see the after pinching, the MP joint is extend and the IP joint is flexible. So from my experience performing pollicization, for 5 years ago, I went to a Scottish Rite Hospital and learned from Dr. Izeki and Dr. Oishi, and learning from their techniques, details of pollicization. Yes, from this experience, I developed my own technique, combining hands-on learning with the core method of these skilled surgeons, as well as techniques from Dr. Upton, Dr. Gossin, and Dr. Zancolli. So I do this pollicization surgeries after reading their articles. And from my experience performing pollicization, I have observed that both function and appearance are critical for successful outcome. To achieve an aesthetically pleasing thumb, I divide the normal thumb into 4 aesthetic subunits on both the palmar and dorsal sides. The distal phalanx subunit, we can see the normal side, the distal phalanx subunit, and proximal phalanx subunit, and transition subunit, and metacarpal subunit. And transition submit, and I think is very important from the proximal phalanx submit to the expansion of the metacarpal unit, cover the trapezius shape. So if we did the after pollicization and the no transition submit, just like chief phalanges. Chief phalanges not is not like a normal sum. So next, I will discuss how my surgical design to build up the techniques. The surgical design begins with mapping out incision or anatomic points on the index finger. Point A is positioned on the palmar midline of the index finger. It is the most proximal crease of the PRP joint. Point B located on the dorsal midline of the index finger at a point 3/4 of the distance distally between the MCP and the PRP joint. So more distally and makes the phalanx submit more shorter and the transition submit locations MP joint. Point C situated around the ulnar mid exoplane within the web space between the index and the middle fingers, and the point D positioned on the radial mid exit side of the index finger, just proximal to the second MCP joint. Connecting these points in a manner shown. These reference points guide our incision and structure the finger's resection. Next, I designed the S-shaped incision beginning at point D with a dorsal to palmar cover that transitions to a palmar to dorsal direction. Point E represents the first peak located at the mid-shaft left of the metacarpal bone. This specific incision layout enable effective mobilization of the tissues, facilitating optimal thumb formation. The blue spots are located on the transferred index finger, while the red spots are positioned on the radial side of the hand, so serving as fixed reference points. And the design of point B in this design marks a significant improvement over previous techniques. Point B plays a critical role in reconstructing the transitional submit of the new thumb, which I will show later. This design is particularly valuable because it provides easy access to the radial and ulnar lateral bands, which are essential for the reconstruction. This tapering reversed triangular design is intentionally kept slightly wide to improve the radial aspect of the skin over the new thumb's metacarpal area. By expanding this region, we ensure that there is enough skin coverage to support the thumb's functionality and mobility. Point E is intentionally designed with a curved dorsal to palmar orientation to increase the amount of dorsal skin available. This design is crucial because in the post-operative phase, the new thumb will be positioned in a functional original abduction, extension and pronation, which places great tension on the dorsal skin than on the palmar side. Without this specific design, there would be insufficient dorsal skin to support these movements, which could compromise both the thumb's functions and its aesthetic appearance. This slide shows the pre- and post-operative comparison, highlighting the relocation of the key points discussed earlier. You will notice that point B is shifted to align with the location of point E, creating the foundations base of the transitional submit. Similarly, point A is reposited on the palmar side, mirroring this structure. Once the S-cuffed incision is opened, the reversed triangular flap on the radial side will be placed between these points, providing additional coverage and contour of the new thumb. Finally, point C will be positioned in the first wave space. This design of the dorsal aspect of the index finger demonstrates that the new thumb in this transitional zone will resemble the normal thumb. We see the lateral band exposure from the dorsal aspect from here, and the metapharyngeal joint area is here. And here is and the tip of the new thumb is either at the same level as or does not exist the PRP joint of the adjacent finger. The left is normal thumb, and the right is after pollicization. After pollicization, we can see from the subunit, the thumb is look normal. And next, I will describe my surgical technique in details. And begin with the palmar dissection, starting from the radial side and progressing toward the ulnar side. The dissection is performed beneath the deeper of fascia, exposing the dorsal intersects muscles. The neurovascular bonds are identified and preserved without separation, to expose the flexible process longus tendon. The A1 and A2 pollices are inside longitude. The bifurcation of the common digital artery is identified, and the radial branch to the adjacent finger is ligated. The ulnar digital nerve of the index finger is carefully split proximally, and the faces are separated to facilitate the relocation. This is the neurovascular bonds and radial digital artery branch too. And to elevate this flap, to notice the to close the neurovascular bonds, and make the flap facials is flap, not make the flap necklaces. After securing the superficial veins, EIP tend, EDZ tend, and the radial and ulnar lateral bands are identified. This is, we can see the extend tend and superficial. This shows the function of the lateral bands in DRP joint extension. This on the lateral band and EDC and ERP. the radial lateral band and ulnar lateral band functions. So I like the dorsal incision to expose the lateral band. Yeah. And the volar and dorsal interstices muscles are carefully disserted and mobilized. During dissection, special attention is given to avoid injury to the underlying collector ligaments, and the neurovascular bonds to the interstices muscles are preserved. The metacarpal bone is exposed to its base, preparing it for the planned osteotomy. This is institutional muscles. This is institutional muscles. The osteotomy site. And the osteotomy is performed transversely at the epiphysis, and the epiphyseal abrasion is then carried out. Care is taken to avoid injury to the MCP joint capsule and the collector ligaments. This shows the metacarpal shortening and repositioning. And the oblique osteotomy is performed at the base of the metacarpal bone. Next, the MCP joint of the index finger is positioned in hyperextension. This is achieved by suture the bone cut surface to the joint capsule at the base of the proximal phalanx using non-absorbed sutures. 2 KY are then inserted through the head of the metacarpal bone, one positioned longitudinally and the other obliquely. Afterwards, we use the non-absorbed sutures to secure the base of the head of the metacarpal, initially leaving the knots united. The new thumb is repositioned to its ideal location. The KYs are raised and the suture knots are tied. This technique is based on Dr. Izeki's approach, which I use in my practice. And these other techniques, such as Dr. Upton's, involve rotating, resection, and positioning the metacarpal head anterior to an oblique cut at the base, with the MCP joint held in hyperextension. And Dr. Zancolli's technique is modified and partially removes the proximal portion of the metacarpal head while it is in a extended position, and then sets it onto the base of the metacarpal bone. And Dr. Zancolli's these techniques I learned from last 2 weeks ago. So I think maybe this is more easy and more can make the new positions to fix the base of the metacarpal. I think next time I will use this technique. And tendon rebalancing is another critical aspect of the procedure. The radial lateral band is connected to the dorsal interstices muscle, while the ulnar lateral band is aligned with the volar interstices muscle around the PRP joint level. So after the pollicization, the dorsal interstices muscle will become the abductor pollicized briefs muscle, and the volar interstices muscle will be the adductor pollicized muscles. And note that I connect the lateral bands to the interstices muscle from the dorsal approach, not the volar. So Izeki's technique is cut the EDC and suture the EDC from to the dorsal of the metacarpal. I suture the EDC from the radial side. Radial side, I think is no like anatomy is APB, no, this is not APL, right side APL, and I sutured, I cut from the distal EDC, makes the tendons longer, and then we can suture the CMC joint strong. We can suture from here and return to the base and to the distal, so we can make the CMC joint strong and stable, make the CMC joint stable. And the EIP, exact technique, shorting EIP, but I shorting EIP and suture the EIP, also suture the EDC and make the more extend tension, and the different the exact technique, the EDC sutured to the radial to EDC sutured the dorsal instructions. So I sutured the radial lateral band to the dorsal instructions. So this is a little modified from the Izeki tendon rebalancing. Yes, so this is APL is a radial, suture radial, and the loop shorting of EIP and the EDC suture together to strengthen the extend. Nothing needs to be done to the flexor tendon. It will adjust to the new tension over time. I think this picture is draws very good. He was drawn by my fellow Dr. Papat. She drew these pictures for me, and so I will extend why uses suture this instrument. This is a PRP joint extend anatomy without shorting the extended tendon and using a dorsal approach to the lateral bands. Botnia deformity can occur when the extended tendon become lax. The lateral bands on the volar side take over as the primary pulling force, which can lead to the development of this deformity. So like this. So sometimes I see that this is the MP joint limited extent, like a PRP joint botnia deformity. So so we can think from this deformity, we can do to prevent this deformity, we can do perform extended tendon shorting and approach the lateral bands from the dorsal side. So the dorsal approach of the lateral side, and so we can prevent this deformity. Since after surgeries. The radiography shows the post-operative result after pollicization. Is after pollicization. This is one of my patients. She was 12 months ago at the time of pollicization. You can see it's a good position and satisfied aesthetic submit of the new thumb. This is after surgeries. The function. So when he extend MP joint is extend, not have limited extend, and the flexible IP joint is very good flexible. So look more like a normal thumb. And this is another patient is 17 months old ago at the time of surgery. So after 7 months post-operative. She has a good fine pinch and strength, and the fourth rib space is not contracted, allowing her to grasp large objects and perform other basic hand functions well. Thank you for your attention. I would also like to express my gratitude to all of my mentors, Dr. Iseki and Dr. Oishi, and Dr. Zancolli, to support and for providing me with the opportunity to learn and grow in this Pollicization. I learned from Scottish Rite Hospital's video, Make a Thumb, and so thank you very much.
Thank you very much, Dr. Shen. This was I think today we have two incredible master classes about thumb reconstruction, Dr. Kosin and Dr. Shen. And probably now we can have some time for questions. Thank you, Dr. Shen. Now we have you with the picture. And probably, I don't know if Dan Sotolov or Dr. Kosin want to comment about the extensor and flexor tendon reconstruction. I know that in the article, they say that sometimes with time, they kind of find their own tension with the use. Any comments from the experts, Dr. Kosin or Dr. Dan Sotolov, if they are connected?
Yeah, I'm here. Hi, Jane. That was a great talk. Thank you. I got the pleasure of seeing her do one of these as well. So I think we have made some subtle differences to our incision as well. And I think, and in terms of the extensor tendon, I think that part of the reason why we have not had to do an extensor shortening, which we have not done probably for 15 years or so, is that the intrinsic reconstruction really does a lot to extend the thumb. Now, I grant you, I think that the extension of the MP joint is a little bit slower, and I think that has to do with readjusting of the extensor tendon. But I don't know why we get good extension without having to do that, even at the MP joint. And it may have to do with the fact that we don't dissect the extensor, and therefore it comes over and it's still sort of attached to the long finger via juncture probably. But I don't know how to explain it. We don't do an extensor tightening, and we have not had an issue, certainly in the long term, of extension of the MP joint. Scott, do you want to comment on that as well?
No, I agree 100%. You know, we set the thumb in extension, but we've not touched the extensor tendon in at least 15 years. I think it's the same thing as the flexor. I think it's, as babies or as humans, we can add and subtract sarcomeres and make up for a little bit of looseness. I like not touching them. I think doing the least to the extensor mechanism to me makes sense. You know, Z, we also do not separate the lateral bands like Jane demonstrated. You know, we sneak in at the PIP joint and get to the lateral bands, but we don't necessarily dissect them out. I think extensor tendons tend to get stuck easy if you do too much, although Jane's videos are impressive.
Yeah, I think the take-home point to some degree is that Jane, Dr. Shen is an excellent surgeon, and she can do things that many of us can't do. So I think that she can get away with things that many of us maybe not be able to. I think that one of the things for us is the veins are really critical, and we do not like to do any dorsal dissection other than isolating the veins. I think once you get up there and you start dissecting, you have to be really, really careful. You know, I think you have to be cautious sometimes of really good surgeons who tell you that you can get away with things because they can, but you may not be able to. So I think that we don't like to mess around with the dorsum of the thumb, of the new thumb, because of the veins. And so we sneak under the veins on the lateral side to get the lateral bands. And I feel that it's a safer approach, and it allows us to have we don't have to have that point B. I think it's the point B that goes up higher. It allows us to keep more dorsal skin because we come in from the side. And I think that allows for an easier reconstruction of the dorsal part of the thumb proximally. And Jane and I talked about this when we were just in Vietnam together. I think that if you feel comfortable dissecting around the veins and you want to do a dorsal approach, I think that gives you great access. And there's no question it gives you better access, but I think it's safer to go around the side. Do you have any comment on that, Scott?
No, I think it is safer to sneak in from the side. I do. Dan, the other, Pablo, I'm sorry, I'm taking over your job a little bit. Dan, the other question that's in the chat box is how do you identify any branches to the skin to avoid superficial epidermolysis, which I think is a great question. So why don't you take that one on?
Yeah, so epidermolysis is I wish I had that solved. I think that the big thing for us, or certainly for me, is I do a lot of knife dissection to try to keep as much fat and as much vascularity on the skin, particularly that volar skin flap. That's where you get the epidermolysis. And I think that as long as you keep that as a full thickness flap, and I try to preserve any vascular supply to that flap that I can spare, meaning there's some vessels that are crossing in front of where you want to do of where you want to transpose the new thumb neurovascular bundle. But if you can get away with leaving as much as you can on that flap and not skeletonizing the artery on the then I think you're better off. But nonetheless, you're going to get some every once in a while. I have not completely avoided that. Jane, do you have thoughts on that? Do you have problems with tip necrosis of the volar flap or any epidermolysis, or any tips to avoid that?
I elevate the very close the artery, the more facial at the in the skin in the flap, and to prevent to the thin skin like skin graft. No. We do the flap is more facial. You use the bread sharply to elevate.
Yeah. So similar. Yeah. Yeah.
I wanted to ask a question. You know, sometimes is difficult according to cultures and everything, and families to say, okay, we will take a thumb and we will transpose the index. I think this is something that has to do with different cultures. Do you use a toe-to-hand transfer sometimes to reconstruct the thumb? Any special situation, Dr. Shen?
Type 4, type 3, type 3B or type 4. Yes, sometimes I use the toe to transfer. Yes, Chinese parents sometimes demand you to keep 5 fingers. Yes, I can do.
I wanted to check this. They told me that in China, 4 is not a good number, and so people prefer to have 5. It's like bad luck number or something like that. Is that true?
No, for 5 fingers, because the parents think sort of the can't be defect because of parents say only 5 fingers, only keep 5 fingers, not the number 4, not because it's the number 4. If a number 4, he can't accept the 3 fingers. He can't just 5 fingers. And then the sum function is not good. They can accept.
Okay, thank you very much. You know, Dr. Shekhar told me once that the best thumb is the thumb that is the finger that the baby puts in his mouth, because in his brain he has that finger as a thumb. So most of these kids with thumb hypoplasia, they put the index in the mouth as they do with the thumb. So he told me it's much better to do pollicization than toe to hand. Any thoughts about that from the experts? Because it's already the brain is has the index finger to be transposed as a thumb in the brain.
Yeah, so can I answer that one? I think that there's no question in my mind that a pollicization is a better functional result than even a 3A reconstruction. I don't think there's any question about that. I think Michelle James showed years ago that pollicizations had better range of motion and better function than even a type 2 reconstruction. So I think that the pollicization is the operation if you want function. I also think aesthetically, it's a much better operation than what Scott just presented of the type 2 and 3A reconstruction. They just look better. And I think that part of it is as you say, there's culturally people want, and I think it in the US as well. I think it's really hard to operate on a thumb that is there and looks so reasonably good, right? So I think that the reason to reconstruct type 2s and type 3As and type 3Bs and even 4s, which Jane can do, I think is parents wish to have that done. But if you look at these kids, many of them, most of them, I would argue, are going to use still their index finger as their thumb. And you can see that. For us, when we look at these kids, I just give them a toy, and whatever they use to pinch, that's what's going to be the thumb, right? If they use their thumb, if they use their type 2 thumb, then they're going to have good function with that once you reconstruct it. If they don't use it, they're just not going to have great function with it. The brain's already moved on. Yeah.
Thank you very much.
Sometimes Chinese parents, they think 5 fingers is not my fault. 4 fingers is my fault.
So Jane, do they blame themselves for the? Is that what you're saying? They blame for themselves for the lack of thumb.
In Chinese surgeons do very well. The pollicization is not too much, and many surgeons after pollicization is not look good and not good function. So I think this is another reason for parents to choose whatever 5 fingers is similar as pollicization is the result. Sometimes, I think many cases is not very good functions, and I think they didn't to learn to reading articles and to learn like Iseki's video, like yours little arms videos to learn the real pollicization technique. Some surgeons just short metacarpal.
There's a question. At what age do you prefer to perform pollicization, Dr. Jane?
1 year, 1 year
One-
old.
1 year. Do you evaluate the stiffness of the index finger before transferring? If there is stiffness, do you change your indication or?
Yeah, I have a case. The index finger function is not good, and each muscles defect. So after pollicization, I transfer the mini digital muscles to do the hoop oppositions again.
Thank you. Andres, do you see Tarek online? Not really, no? I have been trying to contact him, but
I think he's not.
I find very interesting what you say about the translocation of the lateral bands, although probably not to do in the first surgery, but if one is seeing that there's flexion at the new MP joint, this can be the cause, no? The boutonniere kind of deformity. So very, very interesting to understand this as you show in the very nice pictures, Dr. Shen. It says another question, did you see shortening of the pollicized finger in ears? Do you see shortening with the growth of the child, or do you have that experience? They are asking that in the chat.
The after surgery is with grow up, the metacarpal is longer. My case I didn't, but I have a case from my ex-teacher's case. I would do the reoperation for him. Yes, I think maybe it's very difficult because the metacarpal is long and the short is not only short metacarpal, and his extend also is I don't know how to do the just like pharyngeal, but it's a shorter metacarpal at the first many years ago. Many years ago, did by my ex teachers.
And just to ask you the position of the new thumb, the nail position according to the hand. Do you look like 90 degrees, 100 degrees of pronation? Any tip about that? About the new position of the finger to put the new thumb?
Not good pronation. A little. Yes. Second, after exercise can make it to like as a patient not do pollicization. Sometimes the father and also have 5 fingers, and the child I have tried pollicization, and I found that his father also have a transferring, but he didn't do pollicization. But his father is adult, and his some fingers a little pronouncing and pronouncing to after the many years functions uses this thumb.
Pablo, can I make a comment? Hey, Pablo?
Yes, please, Scott.
Yeah, so I think it's important, actually. I think you can both under-rotate and over-rotate. Right, I really do. I think that you have to be careful. So typically, I ask Z what he thinks, he asks me what he thinks. And once we both agree that it's the right amount of rotation, then we quit and go home. But I think it is an advantage of using a longitudinal K-wire, because it allows you to adjust the position versus transosseous sutures. Transosseous sutures, they are what they are. You can change the sutures, don't get me wrong, but you can't do the fine tuning. But Dan and I have both under-rotated and over-rotated. I don't really have a number, just so you know, we don't look for a number. It's just the right amount of pronation and not too much pronation and not too much supination. But I do think that's worthy of taking the additional time. And the one we did last week, because we had the longitudinal wire, we advanced the skin a little bit more palmar, right, which allowed more pronation. Does that make sense? So those minor modifications you can do with your skin insetting, and then it's another Peter Carter rule. Don't let anybody other than yourself or your partner put on the dressings. Because with a longitudinal K-wire, you can under or over rotate with your, just simply with your dressings. But I do think rotation is critical because you don't want to come back. I think that if you can avoid coming back, it's a win. That's why we tend to wait until they're closer to 2 versus Jane when they're 1. Different school of thought.
And if I can also make a comment about length of the thumb, I think that Jane made a really good point about trying to stay below the PIP joint of the next digit, right? And one of the things that happens, I don't think, just to answer the question from earlier, I don't think that undergrowth is, I've never seen that as a problem. I've never seen, because you're not getting close to the physes of anything that you're leaving behind. What we do have problems with is overgrowth. And you saw Dr. Shen mention that she does an epiphysiolysis or whatever it is, just to removing the physis. We accomplish the same thing with that transverse cut, but I think what happens is that you want to make sure that that metacarpal head does not overgrow, because it does have an active physis on it, and you are keeping that. So that's where we've seen getting into trouble, and you have to monitor that on a yearly basis and get on it pretty quickly if it starts to grow, because it's very difficult to shorten a thumb that's already gotten more length. All the soft tissues are now out to a different length, and bringing them back can be pretty challenging.
Thank you, Dan.
So Pablo, the only time I've seen the thumb too short is there's an old technique, and I think it was written by Bill Kleiman, but I'm not 100% sure, where the thumb is docked in the carpus. So instead of the metacarpal. I dissuade anybody from trying that technique. It's very difficult to get the thumb stable versus the bone to the bone, but that gave me too short of a thumb. And a little bit of an unstable carpal metacarpal joint. So maintain the base and dock the metacarpal head in the base.
Thank you very much, Scott. Let's see if there are any other questions. Not really in the chat. So we are already 1 hour and 20 minutes. I think Dr. Tarek is not showing up, correct, Andres?
Yeah, it was a great discussion today. Thank you to all the panel, Dan, Scott, Jane, Pablo. I think we learned a lot today. It was a great PULM talk. Thank you.
Oh boy.
Look, all these
And all
people.
the stuff. Look at all the stuff around Jane.
Now I'm jealous. Now I'm truly jealous.
For sure, it was a masterclass, eh? It was.
Hello, Dan. How are you? We love her. We love her. We love her. We love her.
We love
She's the
Jane.
best.
She is the best.
Yeah.
Bye-bye, everyone.
Bye-bye.
Bye.
Bye.
Thank you very much to all.
Thank you.
See you soon.
Freezy's
You-
talk that she.
Chao, Andrés. Gracias.
Gracias, Pablo. Estuvo de 10. Saludos. Saludos a todos.